Welcome to the Medical Support to Irregular Warfare podcast, an initiative to discuss and educate the evolution of medical support in peace, security, and conflict in uncommon environments. Points, perspectives, and opinions voiced here are solely those of the contributors and do not represent any formal association or government entity. We do everything possible to ensure the information and discussion is sound, comprehensive, and from the most credible sources.
Welcome back to the Medical Support to Irregular Warfare podcast. My name is Mark Anderson. I serve with the Medical Support to Irregular Warfare, or MSIW committee with the Special Operations Medical Association. On today's episode, we are very fortunate to have retired Army Colonel Derek Licina. Derek has done a variety of things. I'm going to introduce him briefly and then have him fill you in a little bit further on his background. But Derek has a master's degree in public health from USU, a doctorate in public health, specializing in global health affairs from George Washington University. He works as an adjunct professor at the Millikan Institute at GWU and is a consultant with the Joint Trauma Services. Derek, thank you very much for taking time to be on our podcast today.
Hey, Mark, thanks a lot for allowing me to join you and your audience today. I appreciate it and look forward to the conversation.
So the reason for the invite, Derek, is that you've been the lead author on a published document, a journal article called Medical Support to Irregular Warfare, a Systemic Literature Review, 2000-2024, which was just published in Military Medicine Magazine. When we were made aware of this article, we wanted to reach out to you and bring you on the show to describe for our audience how you went about finding this information, analyzing it, and what are the lessons learned and key takeaways that the soft medicine community writ large and everybody who's got a stake in irregular warfare can learn from this.
So again, thanks, Mark, and to your audience, thanks for dialing in today. I look forward to having this conversation with Mark and then obviously getting your feedback, hopefully at the end of it. But as Mark stated, I served in the military for right at 24 years, and in the last 10 years of my time, I served in this nexus of what we called foreign policy, national security, and health. And the DoD has a name, they call it global health engagement. And I was fortunate to work in that space, both in the Indo-Asia-Pacific region and also the Middle East more prominently. But during my time in defense, I was fortunate to work with and be assigned to both 1st Special Forces Group based out of Fort Lewis, Washington, worked with the TSOCs, both in Indo-PACOM as well as CENTCOM, and was quite early on in my formative years exposed to OST SOLIC, where I worked as a fellow as a young Army captain. I got to say, it was probably one of the most influential assignments in my entire military career. And that kind of leads into a bit of why I leaned into this space and pulled the team together to look at this topic. But to kind of round it out, after I retired from defense, I moved into the consulting sector, as Mark stated, and worked 2 years in the United Arab Emirates. And then also came back here to the United States for a couple of years working in a top 4 consulting firm before joining the Joint Trauma System, which quite honestly, a lot of the folks that come from the IW space continue to serve in that organization. It's a pleasure to work with them. So I guess why, right? Why did I get involved in this? As Mark stated, I think you all out there are the practitioners. And I recall when I was a non-clinician, but a medical support person with 1st Special Forces Group, I kind of look back at our experiences doing JSETs and, on the border of Thailand and Myanmar, wondering what the long-term impact of those efforts were. And after that experience, having come out of right after 9/11, going down into the southern Philippines as part of the first 30 push that was in there with 1st Group. And, that experience kind of really honed what we did and why we did it in this space, the through by with unconventional warfare piece, right, and counterinsurgency, a bit of all the above. So I really questioned the efficacy of those efforts. And so I had the chance after 1st Group to go back to graduate school, where I studied a master's in public health, looking at international relations. And after that time, I went up to OST SOLIC, both as a student and then as a follow-on 1-year fellow. And I worked in the humanitarian assistance and disaster response space. But at that time, I got to work with guys who literally ran the Phoenix program in Vietnam, right? The Assistant Secretary of Defense at the time, Wayne Ishimoto, an iconic legend who was actually in Iran during that initial effort to bring jointness to this community. So I was fortunate to be surrounded by them and try to get a better understanding how we, the medical community, support and enable them, right? But that experience, again, also gave me pause. It gave me a lot of questions, and I still have many questions. And one of those is, how do we move this community of practice forward? So with one of my George Washington University's master's students, we just reached out to some counterparts in OSD SOLIC, SOCOM, and a couple of organizations and asked if they'd be interested in kind of doing a systematic literature review to figure out what can we learn from the literature. Again, not anecdotes, not our personal perspectives. What does the literature tell us? And so we took an academic approach to looking at that literature and kind of, as Mark stated early on, categorizing it and then drawing on it. And it's not just defense, right? We wanted to cast a broad umbrella and look at not just public sector, but private sector as well. What are nonprofits and NGOs doing in spaces like Yemen, right? Or in Syria? What can we take away from them and their efforts? So we casted a broad net and we published our findings. Again, we had some colleagues from OSD SOLIC. We had colleagues from the SOCOM Surgeon's Office, Joint Special Operations University, the Joint Trauma System, as well as some of our colleagues from the George Washington University that were co-authors with us. So, Mark, I know it's a longer intro, but hopefully it sets conditions for the conversation. And you tell me when. I'll go ahead and try to share these slides, and we'll talk through them, like you said, about 10 minutes, and then we'll have that conversation. I look forward to that, if that's all right with you.
Perfect. Yeah, that provides the foundation of knowing where you're coming from. So if you're able to share that slide deck and brief this paper,
you bet.
That'd be fantastic.
Let me give this a go here. And I recognize not all your audience is viewing this from a desk. So what I will do is I will be talking to the slides for those that are commuting into locations like Fort Bragg or elsewhere, and that can still get the same understanding without the slides in front of them. So with that being said, just as an opening conflict of interest statement, I have none, right? And these views are my own, and they don't represent the Joint Trauma System nor the DoD. That is my non-disclosure up front. So as stated, the purpose of this effort was to look back. What can we learn since 9/11 as it relates to medical support to irregular warfare? And how can we take a systematic literature review approach to find what that literature can tell us? So I guess the outline of this quick 10-minute highlight is going to talk about the scientific methods, right? Because that highlights the validity and reliability of our findings. And then also present these results, talk about some of these key observations that we had coming out of the literature, and then highlight some conclusions that we took and also some next steps that highlight what the DoD is doing. But we acknowledge it's not just the DoD that is working in this space, and all your viewers, I think, fully appreciate what I'm saying. But our time span, right? We're looking at 2000 to 2024. This is when we initiated systematic literature review. So it was a 24-year period. And in terms of this approach that we took, we leveraged the expertise of Chelsea, one of our MPH students, to help us with the methodological approach. But we looked at categories of specific terms, and we used those terms to search databases. And so these terms fell into 4 different blocks, and they related to irregular warfare, trauma, what we refer to as an acronym as MLPF, so that's doctrine, organization, training, material, leadership, personnel, facilities, and policy, right? We also looked at practice and policy terms that could be related to regular warfare, and then also non-essential terms. These were terms that were of interest to us, so things like partnership, cooperation, collaboration. And so Chelsea put together the methodology with support from our GW University library, who has expertise in these scientific methods, to search databases. And they actually searched 88, which is quite a few. Intentional, right? Because we are viewing irregular warfare as not just a medical issue. We know that it has inputs and drivers from many different domains, and we wanted to make sure we captured what's coming out of social science, not just the medical community. So some of those databases were PubMed. All you folks online that are medical professionals, you recognize that, or ProQuest for another example. If any of you all have completed a terminal degree like a PhD or a dissertation, it gets published by ProQuest. So she went through with the help of the team and looked at these 88 databases and pulled out from the literature things that were related to our inclusion criteria. And I'll describe what you see on the screen here, but this is what we call a prisma diagram, right? And this is what academia uses to highlight the scientific approach to their literature review. And at the top of it, you can see there's a big number, right? What did we find when we searched by these terms across these 88 databases? We found over 12,000 articles or products, both gray literature and peer review, that were related to those terms that we searched for. And many of those are going to be duplicates, right? Some things that might not be related to the specific topic. So you have to start to exclude, and you have exclusion criteria. So things that didn't align based on the title or after reviewing their abstract were excluded. Those duplicates were excluded. If they were missing the full text, right, they were excluded, etc. And then we also added 2 reports because we thought they were incredibly important that didn't meet our search criteria. So after accounting for our inclusion and our exclusion criteria, we ended up with about 1,000, like 1,063 pieces of literature to review. That's a ton, right? Anybody who's done one of these knows that your sweet spot's about 100. We're 10 times that. So it's a significant amount of work to undertake, but we wanted to throw that broad net intentionally just to see what we can learn from the other sectors. So on this next slide, we highlight where the literature was focused by region, and we use our combatant commands as the regional frames. And as your audience, Mark, can probably imagine, right, most of the literature, because scientific people and medical people like to publish, came out of this CENTCOM AOR, Central Command Area of Responsibility. And that's not a surprise given what we have seen over this period of time, in particular coming out of Iraq and Afghanistan. But in total, for the audience, actually 81 different countries were covered in the literature. That's a lot. And every combatant command was as well. So CENTCOM certainly had the most at 690 items met the inclusion criteria come from that region, but AFRICOM was represented, EUCOM, you name it, NORTHCOM, INDOPACOM, SOUTHCOM. So think in AFRICOM, right, the Sahel region itself, or northern Ethiopia, right, you've got Democratic Republic Congo, many different nonprofits that are operating in this space and had some interesting insights for us. In EUCOM, clearly Ukraine featured prominently, but you had some other products coming out of the Balkans too. NORTHCOM, interesting one, but you can think about CT efforts along the border with Mexico that may or may not have been included, but they were. INDOPACOM, no shortage of UW and COIN and FID efforts taking place out there, whether it's part of OEFP in the Philippines or work that's being done by the private sector or other public sector along the border between Burma and Thailand, or things related to the Rohingya refugees up in Bangladesh, right? And then Southcom, I will tell you, Colombia features prominently as well. But every combatant command was represented. And so we looked by definition in terms of how we were extracting data at a couple different factors. So we wanted to know what area of irregular warfare was discussed. And by doctrine, if you're looking at the newly published DODI on irregular warfare, it breaks it down into 5 areas. And again, your audience is well versed in it. And these include counterinsurgency, counterterrorism, UW, stabilization, and foreign internal defense. In our literature findings, we found 30% were talking about counterinsurgency. Again, no surprise looking at that time frame from 2000 and 2024, right? It's primarily Afghanistan and Iraq. CT featuring next, followed by UW and stabilization. I guess you can make a logical cascade there. What was surprising, though, is a dearth, right? The lack of publications on foreign internal defense. And that only was 2% of the total. There was a larger group, about a third, that were just talking about irregular warfare in general. That's how they were coded. But nonetheless, some interesting insights, but yet not surprising, with counterinsurgency featuring most prominently. And as Mark set it up front, we're interested in looking at the .MLPF construct. So when we in defense talk about building a capability, this is the joint construct that we use. You have to have things like doctrine, organize the services and the Department of Defense to provide that capability. You have to train that capability, have material solutions, etc. So we wanted to look at these 1,000 different pieces of content that met the inclusion criteria to figure out, what does the literature tell us? And most of it was telling us how organizations are structured or could and should be structured in the future to support irregular warfare. Again, remember, not just DoD, this is private sector as well, and how they might interact on a regional basis with the World Health Organization, or how NGOs are organized within countries to deliver services in places like Syria, et cetera. But you can see there's equitable representation too along the personnel, training, policy, and doctrine constructs. So those were about evenly distributed between 15 and 13% of the total that we reviewed. What was a bit more surprising is the fact that materiel, so think logistics, right, was at 10%, leadership and education was at 8%, and facilities at 8%, were discussed the least. That may be surprising to some, but maybe not to others. I thought the leadership and education being at 8% representative was a bit underexpressed. So nonetheless, that's on the education side. The training, again, did feature prominently at 15%. In terms of medical functional areas, so the DoD, if you read the Joint Doctrine on Health, they break up the functions for the health capability into two buckets. And it's focused on health service support and then force health protection. Health service support includes things like medical treatment and medical logistics, evacuation, et cetera, right? And then the force health protection side is preventive medicine services, laboratory support. We actually looked at the literature and coded each of those items, and we found that medical treatment featured prominently, overwhelming. A majority of the articles in gray literature that we found were talking about medical treatment. And really, that's more on a tactical level. That was followed by medical logistics, preventive medicine services, and medical evacuation and medical mission command. To me, what's interesting about this, if we have two buckets, health service support and force health protection, and both of these inform how we provide IW medical support, if you look at the amount and I guess of literature that's out there, it leans heavy towards health service support. In the top 5, there's only one that's focused on force health protection. That's it, preventive medicine services. All the other force health protection inputs fall to the bottom, right? So we didn't find nearly as many articles focused on combat and operational stress control, medical laboratory support, veterinary services, and dental services. There are only actually 5 in the entire list of over 1,000 we found. So nonetheless, an interesting construct when thinking about from a health service support and force health protection. And so after we coded each piece in terms of what it represented from a .ml-PF construct, a medical functional area, where it was published, by whom, et cetera, that's all demographic characteristics. We had the research team look at key findings from each of the articles, some weaknesses and challenges, actions, policy, and future research recommendations that came out. And for your audience, Mark, I'm just going to highlight a few here, but some of those key findings were that interagency and multinational synchronization are essential. It's no surprise there, but the fact is, when it works, I think IW medical support functions, but when it doesn't, obviously, we've got challenges. Global health engagement, it's, again, an area that I know and I've worked in over a decade. It was highlighted as an important enabler in the literature, but there are also some criticisms on the challenges in terms of its efficacy. Like, what is the sustainability of what our TSOCs are, for example, doing in the global health engagement space with their partners, whether military or civilian, in each of the regions? Low signature operations drive new needs. Your audience on the PFC podcast know that one better than me. Ethics and human rights, those issues remain a concern. And it's not just for public sector, for DoD and other military organizations around the world. This is as it relates to the private sector too, providing support, whether that's through nonprofits, businesses, et cetera. So those ethics and human rights issues as it relates to the duality of obligations to military mission and also your obligations as a military medical professional on the Hippocratic Oath. So those are a couple examples of key findings that came out. Some weaknesses and challenges for your audience. Clearly, there is inconsistency in training and doctrine as it relates to irregular warfare medicine, and certainly significant barriers to international cooperation. Some of the literature in terms of actions, right, it is pretty clear that there is a need for IW medicine doctrine. And this is explicitly true for the Department of Defense. As far as I know, it currently does not exist, nor did the literature highlight that it does. Strengthening local capacity and training is absolutely fundamental for this capability to move forward. And enhancing trauma and casualty care is a key area of recommendation. Most of that would come out of places like Iraq and Afghanistan, where our organization, the Joint Trauma System, has learned a lot. But it's applicable to all of those 5 different areas of irregular warfare, not just COIN. It applies to or unconventional warfare, FID, you name it. And that's the system approach to trauma and how we provide support to our casualties. The last 2 domains that we coded for, we looked at policy and feature research. So policy recommendations, something that clearly emerged from this breadth of literature, saying that we need to magnify this multilateral cooperation and interoperability. Mark, your audience knows that just last week, the brand new national security strategy came out from this administration. And multilateral cooperation historically has been an area that we, the U.S. government, were investing in, but the national security strategy doesn't really speak to it. Quite frankly, it takes more of a bilateral approach. And if there are any historians on the line here, they know that that's the way the PRC operates. They don't really designate nor donate to multilateral institutions on a level of other peer countries or OECD countries. They invest in the bilateral space. And that is kind of what is coming out of the national security strategy as well, and building regional networks through bilateral means. So I think that policy recommendation is something that we in this community of practice could and should move on. Enabling veteran care and reintegration. Some of the audience might say, okay, why is this unique to irregular warfare? It's, again, you think about all the other organizations that are operating in this space, public and private sector. Reintegration of that population back home with family, with communities, absolutely vital for the success of not only them as an individual, but for the organization and the people that they serve. Finally, in terms of future research, advancing medical logistics and prolonged casualty care was a clear area of recommendation. And then countering medical disinformation. This one I think is a bit newer to the general audience, but for your audience online, especially those that have worked in the white soft space, they know the role of information and the power of it. I think just coming out of our literature, need to come up with a proactive approach to counter medical disinformation. Think about how it's being used by Russia in the Ukraine against Ministry of Health and others. It's an area that we could potentially lean into further. The Office of Secretary of Defense for Policies, basically the Special Operations and Low Intensity Conflict Office, they're moving forward on this systematic literature review to really inform some efforts that are being driven by the Deputy Secretary of Defense and SecDef to support irregular warfare, at least under the previous administration. And they broke it down into 3 domains. They're looking at these findings to inform policy strategy and plans, exchange and engagement, education and training as it relates to irregular warfare medicine. And they're partnering with Harvard University to work in this space. And many of your participants here, Mark, are members of SOMA and have attended the SOMSA conference. And Solik worked with Harvard and a bunch of subject matter experts to employ what they call Delphi consensus approach to science, to take these 3 domains and develop research questions to kind of inform and help DoD to progress in these areas. We broke down each of those 3 domains that we talked about, and we came up with a clear definition for things like what does policy mean by joint doctrine, and in our own joint publications, what does strategy mean, what does plans? And then we aligned themes that came out of the literature review that was conducted to each of these. And then those experts that were invited to attend that work group will continue to convene to whittle down what are the research questions of interest that will help address these gaps. Things like enhancing military or civilian and military cooperation, enhancing trauma systems, in particular with our partner nations, focusing not just on defense, but the civilian sector as well, driving medical innovation and technology transition to support IW medicine, et cetera. So they're working through that now. And on the slide, you can see this is some of the themes that emerged from the policy strategy and plans analysis. We did the same thing for exchange and engagements. So think through exchange, how do we share resources, personnel, knowledge across different bodies, things like NGOs and international organizations, so we can mutually benefit. Things that we want to exchange on as knowledge so we can avoid that walk or dip, right? And then some things that we could possibly improve on are cultural competencies and medical awareness to better enable us to be effective in the IW space. Engagements, again, non-traditional medical engagement as well as traditional medical engagement through global health engagement or security cooperation. These are some areas that the team is leaning into. And they did the same thing for education and training. Actually, this is the third bucket. So education and training, that includes interdisciplinary approaches to ENT, looking not just at the medical component of it, but also the irregular warfare component of it to ensure that both sides, the line as well as the medical side, understood each other and what the needs and requirements were. Peacetime continuity of care as it relates to education and training as well were a couple other examples. So conclusions and next steps. The bottom line is whole of society efforts are necessary and could be enhanced through a whole of government irregular warfare medicine approach. And again, goes back to the why we conducted this to understand what we can learn, not just as defense, but as a U.S. government to better enable us to address this mission set going forward. We also determined that exploring long-term health impacts of being exposed to IW medicine on the human dimension is needed. This again came out of the literature, not just as it relates to U.S. service members and other coalition partners coming out of Iraq and Afghanistan with PTSD and TBI, but this clearly came out of the nonprofit NGO community as well. We found that the lack of a clear IW medicine policy and doctrine, there is, again, no IW medicine policy today. And there is, as far as I know, no IW medicine dedicated doctrine. It really obscures roles, responsibilities, requirements, and capabilities. And efforts to advance this provision of medical support in irregular warfare has progressed. A lot of success has been made, but there's really been no cardinal direction or universally shared foundation of knowledge to build upon. So in terms of next steps, again, OSD SOLIC is leading an IW medicine conduct. That's a great initiative that should hopefully kind of provide a bit of a North Star. As mentioned, they're working with Harvard as we speak to conduct this Delphi consensus study that really leans into a capabilities-based assessment approach to build this capability and also inform research efforts that support it. We understand that OSD SOLIC and OSD Legislative Affairs are exploring a National Defense Authorization Act to expand MIL-CIV IW med engagement. So historically, we've done MIL-MIL, and there are authorities and appropriations that allow us to do that. Not the same for MIL-CIV, and that's an important key point, especially when you're thinking whole of government, whole of society. You can't do this without the MIL-CIV piece. And then finally, these study findings from this systematic literature review, as well as a database that we've collated, are available for anybody online or any other researchers to drill deeper on this topic. So that's where I'll leave it. I love the quote on the bottom. For those who can't see it, I'll read it. It says, "The conventional army loses if it does not win. The guerrilla wins if he does not lose." And that's attributed to Henry Kissinger. So with that, Mark, I'll turn it off there and I guess turn it back over to you for a discussion.
It's a fascinating paper. And one of the things that popped into my head almost immediately, and I'm curious, where was the literature you're able to find? You described that it covered all of the geographical combatant commands in terms of, analysis of key interventions or operations or capabilities and so on. But did you find much in terms of literature from allies, partners, and other non-U.S. sources?
Great question. And again, we went broad. And so the answer is yes. We had actually more publications came through from civilians than military personnel. And that's a good indicator, right? So again, trying to learn from those outside our community. But to your specific point, there is some recent work, and I think it was published maybe in support of SOMA or with many of the folks that work with it, coming out of the French Ministry of Defense, right? The soft community there. And their discussion point, I can't remember the details, is we've spent a lot of time talking about the tactical successes. We really need to lean into the strategic space. And if I recall, that one article in particular focused on that topic. Now, granted, we had over 1,000 articles that we had to screen each, and that actually took months between 4 different screeners, and I was one of them. So I didn't read every article exactly, but I will tell you, it's a great question. And yes, we did see a lot of publication from other nations, but I will caveat the statement that we screened with just 3 languages because our research team had folks who could speak English, French, and Creole. So we're thinking about Haiti, if it were to be included in one of those areas, right? If we had any articles that came out of there through UN peacekeeping operations or other type of publications. So we were constrained by language. So if, say, a Baltic nation published something on this topic and it was not in English, you're correct. We did not include that. And so it's a missed opportunity. We call it limitation, right, in the scientific community of the study findings. But again, 1,000 different pieces, 3 different languages that were reviewed. And we did find representation from many different militaries as well as civilian counterparts from other countries.
Well, language is always a limitation, no matter how hard commanders and
100%.
the system pushes area orientation and language proficiency. It's a tough thing to maintain, and it's a tough thing for us to utilize in scientific research. But it fascinates me to think of what we may be missing that was published in Latin America in Spanish or Portuguese, or what may have been published in Mandarin.
Excellent point. And there is no shortage of it. I will caveat, and it's not to say the point is not valid. It is. There is a common language in medicine, which is unique from other professions, and it is English by default, for better or worse. And so that is an interesting common thing that we have, but your point is not lost on me. You're right. The PRC is certainly active in this space. And part of the influence campaign, which is a key tenet of irregular warfare, is putting your narrative out. And I would submit that they are doing this in English journals now to try to get their presence more featured more prominently, especially in Tier 1 journals. So interesting obligation, but you're absolutely right. Those were limitations of the study design.
A corollary to that question is, the date range that you were looking for literature. I'm also fascinated with the idea that there may have been a lot published decades ago, many decades ago, post-World War II, that may not get the attention that it deserves.
Sure.
Certainly on this podcast and in the SAMHSA MSIW track, we've talked quite a bit about the memoirs of medical providers who parachuted into southern France to work with the Maquis, or infiltrated Yugoslavia to work with the partisans there. Enormous amounts of knowledge, skills, and experience buried in those memoirs.
Absolutely.
Have you looked into, if it wasn't within the scope of this paper, did you dabble in pushing further back, looking into medical journals and medical literature in the post-World War II era?
Great question, Mark. And I'll tell you, two points come to mind. It's like when I was with First Group, and after 9/11, we launched into the southern Philippines, we were scrambling, looking back in history. You're absolutely right, because we were doing counterinsurgency work there in the late 1800s. No kidding. It's fascinating. But unfortunately, we didn't find much at that time. And then your point about what can we learn from the Jedburghs, even recall when I was up in OSD Solix, stability operations at that time in 2005 was a real thing. And we can certainly talk about that experience, a formative one in my mind, of how the office at least got that right, working within DoD and with State Department. But one of the key tenets there is, what can we learn from Vietnam? And again, we had one of the guys who ran the Phoenix program as our ASD. So we looked at the CORDS program, right? We drilled down on the medical side, and we found a few publications talking about how we provide medical support to irregular warfare. And there's many different legends, and I'm drawing the blank on the one individual author's name, but it's a very prominent piece in the Journal of Military Medicine. And we know that others like Rocky Farr, who have served in this community, have published about guerrilla warfare. Even though the publications came later, it's about that period of time. So it's a great point, and maybe it's an opportunity for your audience here, Mark, is I would argue the methods matter, right? Just to reinforce the approach and also the findings, because otherwise we find, and I would argue in our own daily consumption of news, people publish what they want oftentimes, and it might not necessarily be based on fact or data. And I would argue that if your audience is interested in looking back in that period of time to inform what we could do better, differently in our regular warfare medicine, take a systematic literature review approach. I would say, time bound it, and maybe look at, again, the 5 areas that we looked at in irregular warfare by DoD doctrine, maybe you can take a piece of that. To your point, the UW component of irregular warfare and focus maybe a specified period of time in World War II on UW to see what we can learn, and or work collaboratively with other academic institutions. And maybe you can find the ability to kind of cover all domains over a specified period of time to, again, inform this community of practice, what we do, why we do it, and how we could do it better. Hopefully that provides a response that's adequate to you and your audience.
It occurs to me that many of the people listening to this podcast are frontline medical providers. They are 18 Deltas or SARCs or other guys who are working on detachments,
Sure.
maybe battalion seniors and battalion surgeons, but usually folks who work at the more operational level don't feel like they've got a lot of time to look at medical literature. My sense is that, and friends who are still on active duty at the groups tell me that there are resources available to the guys. They can get access to your article in Military Medicine Magazine by reaching out to Group Med or Battalion Med, and
Sure.
there are accounts that allow them to access online journals. With your specific background of doing this kind of literature review, doing this kind of research, do you think that that's useful? Is it a good use of their time for operational medics to dive into medical literature and access those resources?
Yeah, I would tell you that's the point of publishing, right? Is to inform practice, whether it's at a tactical level, like you talk about, as a provider, or a strategic level to inform policy. That's why we write, not to build a CV. Now, some people do that, don't get me wrong, but it's really to influence what we do and how we do it. That's why I take the time to write. So I would argue everybody's time is valuable. I would tell you from a medical perspective, there also is value in challenging ourselves, our communities, in terms of how we act and what we think. And one way you can do it is by doing research. So I'd encourage the audience, if they are interested, to reach out to somebody within their medical community and see if there's a way to collaborate on a topic that is of interest to them, or a topic that's being pursued by others. And that's the way to learn initially, is to help somebody else focus on a research question of interest and understand the process behind designing a research question, the methods to do that research, and then actually publishing the findings. Because it's a lot of work. Don't get me wrong, it is a significant amount of work. But again, the idea is to, one, develop ourselves, to inform the communities of practice, and kind of move ourselves at least in a forward direction, rather than not maintaining the status quo. There are journals that allow folks that are trying to move into this space, I guess, opportunities to do this. And I mentioned one, and again, I'm not paid by the organization. I have just published in this journal as a Journal of Special Operations Medicine. And ironically, I was assigned to U.S. Central Command many years ago, and this is when they were standing up that journal and capability out of the SOCOM surgeon's office. And the idea was to bring in frontline medics to partner with other experienced researchers on a topic of mutual interest that could, again, help the community move forward. Without that firsthand I guess, experience, a lot of academics were left to just findings from the literature. And not to say it's a bad thing, but it's a nice thing when they can complement one another. So I guess, again, Mark, a long answer to your question, I would encourage your audience, if they are interested, to put in the time, because we learn through that process to find a partner so you can actually work through the research approach, the methods, and the publication process, and then eventually maybe lead your own team to do similar type of research on a product that is of interest to you. Flip side of that coin, if your audience is not interested in it, I would recommend they not pursue doing the research, but I would advocate them for doing the reading, because that is how we learn. Otherwise, we're doomed to repeat the past. We've always got to learn, and you learn by doing, you learn by reading.
Derek, one of the questions that I get when I bring up the subject of medical support to irregular warfare with operator medics or direct support medics, guys in the SF groups, MARSOC companies, etc., is, man, irregular warfare, is this just an effort of the Pentagon to create a new term? What the heck are we talking about? Are we talking about unconventional warfare? What are we talking about? And you mentioned the new DODI that was just released at the end of September. It's actually pretty important for anybody who works in this space to look that up, we'll probably leave a link to it with this YouTube podcast. But yeah, it's important to look at the subcomponents of irregular warfare and understand that there are substantive differences between those missions. What is your perspective on, and what you learned through that literature review of the differences and the commonalities between preparing yourself and your unit medically for an unconventional warfare mission versus going into a well-developed theater to run CT ops or FID ops?
Good question. I would start by saying having a common definition is vitally important because that provides a North Star that everybody can plug and play into, right? Because if we're defining the same thing differently, that becomes very problematic for how we develop mutual solutions. And I say that because, heck, we see that Goldwater's nickel relates to joint terms. And then you take that to the other layer within our U.S. government. How do we work with the intelligence community in the regular warfare space? How do we work with the U.S. International Development Finance Corporation from a development perspective, which, if you haven't read it, features prominently in the brand new national security strategy from last week. So common language is fundamentally key. So if we agree to what IW is in these 5 areas that fall under it, then you can start parsing out details like you talked about as it relates to comparing and contrasting, like requirements for CT versus COIM or UW itself. You better believe the medical planning factors and requirements coming out of our initial efforts in OEFP were different from OEF in Iraq. They absolutely were. But what I would say is, and again, our design wasn't to look at those differences and align capabilities and requirements against each, just to kind of better understand the literature in general. But it's a good question. It's like, I would argue there's probably more things that are similar than they are different across these 5 areas. But that being said, make no mistake, CT is about those elite, highly technical, refined teams going in and doing very discrete mission, direct action mission set, right? And then UW is certainly a bit different, right? You can think about maybe, I don't know, certain requirements are too covert in some regards, right? For robust medical capabilities or your ability for proxies that work in the medical space to take risk on your behalf. These are just smaller examples. And in my experience, and it's the stability operations component, most folks don't realize stability operations does fall under the irregular warfare umbrella. So that's that whole soft power piece, how we work with the civilian population and help build systems that we can lean into and that they can better leverage. So it provides services and credibility to the government, different layers, different requirements. But at the end of the day, I think there are some common capabilities. And what I would offer, and this is something that we at the Joint Trauma System are very interested in, is one of the reasons I've leaned into this space with my graduate students, is like systems approaches, right? Not widgets, not just a single clinical practice guideline. I'm talking a system. If you can build a system, whether it's here in the United States or in a third world country, that civilians and militaries can plug into, it benefits everybody. And ideally, and in a, I guess, irregular warfare environment, it is fully operational. And then it degrades over time based on the current environment and the conditions. But yet you've got the foundation for what the components and the inputs to that system are. So you know who can plug and play and where. When I say that, people's eyes might glaze over. It's like, oh, Derek's talking about system. What I'm talking about, in the United States, a trauma system is the pre-hospital component. So think about your ambulances, your EMS capabilities that feed into trying to sustain life all the way until you can get them back to a hospital, and from a hospital back to a rehabilitation center. And then what are all the components that integrate that system? Things like patient transport, medical logistics. How do we collect data to determine whether or not the care that we provided was adequate and what the health outcomes were? We use that systems approach in Iraq and Afghanistan as well. And it's in the literature, 25% reduction, no joke, 25% reduction in mortality here in the United States if you are sustain an injury in an area that's got a trauma system. In Afghanistan, we saw it over 40%. So again, the JTS early years from like 2001 to 10 found a 44% reduction. 44% reduction in mortality, like soldiers dying as a result of integrating these capabilities through a trauma system. So I'd offer that up to you, Mark, and the audience, and maybe it's something for debate, is like the system is universal across each of these 5 areas of irregular warfare. But I think what's unique is like who you partner with in that system space, right? Is it going to be paramilitary organizations? Is it going to be civilian organizations? So we know that, again, for this to function, it takes a whole society. So it can't just be military dependent. But there are some countries, say like Pakistan, for example, that their military hospitals provide services to the civilian population. So we have to take in mind a systems approach and look at it from a military and civilian perspective and how the soft community and other actors can leverage that for irregular warfare medicine. I just caveat too, IW is not soft specific. It's not. It takes the conventional force, it takes the rest of government and the whole society for it to succeed. We can't be focused just on the cool guy, tip of the spear. This is what the soft community does. For it to be successful, whole of society, full stop. Otherwise, it doesn't work.
It's one of those things that a lot of soft guys don't remember, getting all the way down to the bottom of the list of the soft truths. It's truth number 5, that most soft requires non-soft support to achieve mission success.
Bingo.
So, keeping an open mind, understanding that we are one link in the chain of survival in any given situation, and that chain may include non-military, non-U.S. partners, especially in some of these mission subsets like UW, where that chain of survival is going to be almost entirely dependent on what you can come up with in that, very, very austere, remote, and non-permissive environment.
I mean, seriously, if you really take a introspective look at this, you got to treat medical support to irregular warfare as a strategic capability. You do. It cannot just be a clinical sideshow. It can't. It's got to be a central tenet of strategic capability. And to your point, leveraging all those different stakeholders to make it happen. If not, I think we will fail in this regard.
But we will be having an MSIW track once again at SAMHSA in 2026. And some of these things that Derek is bringing up that he and his team learned in their literature review are going to be addressed. There's a lot of talk about medical lessons learned based on medical evidence, evidence published in Tier 1 scientific journals. If we're going to be an evidence-based medical system, we have to understand how to get at the literature and analyze the literature, and we need to contribute to the literature 100%. Whenever we can. So once again, anybody in the audience, if you can make it happen, you're going to really, really, really enjoy coming to SOMA if you've never been before. And we on the committee encourage you to dedicate time on the Thursday of SOMA week to sit in the MSIW track. You're going to hear people like Derek and people who have a deep interest and stake in all of the contributing capabilities, the med logistics, the med intel folks. We go way out of our way to have international partners talking about their lessons learned and their perspective on their approach to MSIW. So please take some time to take a look at the website, look at your calendar, approach your chain of command, see if you can get some support. Even if you can't get that support, if it's at all possible for you to get there, I think you will enjoy attending SOMA next year. Derek, I want to thank you for your time. I want to thank you for taking the lead on doing this literature review and getting this information out there. I encourage all of our listeners to talk to, if they don't feel comfortable with getting access to medical literature, there's somebody in your unit who is more comfortable. Go talk to your battalion surgeon, go talk to the group surgeon or the group SEMA. I guarantee you that you've got access to accounts. You can be looking at some of these articles. If you're interested, your teammates, your fellow soft medics in other detachments are probably interested as well. And you can be the catalyst and the conduit for getting some of this information out there to the people who need access to it. Thank you very much. Any final words, Derek? Anything that you would like to point to as the single most important takeaway from somebody who has access to reading this this journal article?
Yeah, good question. And so hard one, put me on the spot, single one. I would tell you, if I were to kind of wrap it up, really, it's the fact that I ask that you and your listeners really carry the message forward that IW medicine is no longer just a military healthcare system sideline. It's a decisive front in statecraft. And if we carry that strategic message forward and think how we can better integrate with our interagency partners, again, we throw acronyms around all the time, we throw icons on PowerPoints, but to do it in a systematic, meaningful way that's codified in policy, has doctrine that goes with it, and we start training our people to do it, we really can move this forward. And again, timing is great. Just last Thursday, the brand new national security strategy comes out. And I'm telling you, it's talking about codependence and burden sharing. It's like the US DoD is not going to do it all. We have to find creative ways, creative solutions to do this with partners. And it's just not just government, it's private sector too. So key role for private sector in this space. And I'm sure those that are in the private sector now listening to this podcast are thinking through how they could better support. But again, I want to thank you and the listeners for the opportunity to share this research. And I hope that, again, we inspired some folks to think about this problem set, not only today, but also how they can contribute to that body of knowledge going forward. So thanks, Mark. Thanks to the podcast for having me on. And if any of your listeners ever have any questions or want to learn more from us or gain access to the database, by all means, please share our contact details and we'd love to do it.
Thank you very much, Derek. Hey, to all of you out there listening to the MSIW podcast, please, as I like to say, take good care of yourselves, take good care of your teammates, take good care of your casualties. We'll see you at the next episode.
Thank you for listening to this MSIW program, and we hope that you will both participate and contribute to the notes or offer thoughts, requests, and suggestions via our email link. The best to you, your work, and the relationships and security this effort strives to impact.